Understanding dementia learning objectives. Identify hallmark characteristics of the main types of dementia, including Alzheimer's disease, vascular dementia, Lewy body dementia, frontotemporal dementia, and mixed dementia. Review the newest diagnostic guidelines for dementia. Explore the practical use of assessment scales in the domains of cognition, function, behavior, quality of life, and depression and dementia. Examine person-centered communication skills with patients and clients when delivering bad news and working with cultural differences. And to locate reliable sources of information to further professional education in dementia and to refer patients and clients for support in dementia care.
I'm Judy Smalley, and I met John probably in 1986. John Smalley is my husband, and he is in a special care facility. And I was 40 when I met John. I'd been divorced for a long time. And my friend called and said her husband knew someone that she wanted me to meet. He was a super nice guy, yada, 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 all that stuff. And of course me, I'm done. I'm 40. I'm not into the blind dating. I'm not, no, I'm not doing that anymore. So she just kept on and on and on. And so I said, okay, I will meet him for lunch one day. At noon, he can pick me up outside the courthouse, and I'll go to lunch, and then I can say, oh, I'm so sorry, I have to be back to work. So he was in the military, and he picked me up, and he had on his white Navy uniform and leaned up against his black 280Z. And I walked out of the courthouse and said, that's the man I'm going to marry. And we've been together ever since. So this deal about love at first sight, I was always the one who said, oh, that never happens, that's impossible. But it did. And so he's a great guy. He has a great sense of humor and funny and loving and caring. He's a good Christian man. So that's kind of where we are. So this has been a real hard journey.
Hello, and welcome to our program. We're glad you joined us today for our discussion about the important role of a medical professional in care for persons with Alzheimer's disease and their families. So let's talk about the scope of the problem. Alzheimer's disease affects almost 5.5 million Americans today, and that number is expected to triple over the next generation. 1 in 9 people that are over the age of 65 already have Alzheimer's disease, whether they know it or not. With the aging of the baby boomer generation, we'll be looking at a monumental problem for all aspects of society. And people with dementia and their families will be looking to the medical community to provide them with the support, the understanding, and the guidance that they're going to need as they go through their dementia journey. Alzheimer's disease is the 6th leading cause of death in the United States. And unlike the other causes of death, Alzheimer's disease it can't be prevented and it can't be cured. Many times the disease lasts 10 to 15 years. And it's progressive, and so the role of the caregiver becomes much more important as the disease goes along. We hope this program is helpful to you as you work with your aging patients.
With a large number of people living with dementia today, and the numbers projected to increase to 14 or even 16 million by 2050, it is imperative that the healthcare community have at least a basic understanding of dementia, the complexities that come along with it, and the best ways to support those living with dementia. Dementia is a broadly used term for cognitive decline. Technically, dementia is not a disease itself, but it's a group of symptoms that are associated with an overall decline in somebody's intellectual functioning and abilities. The symptoms of dementia are caused by a variety of different things, but commonly you will see cognitive changes and psychological changes. Cognitively, those changes can look like somebody's having a hard time planning and organizing like they used to, maybe some difficulties with language or communication, or even simple calculations. Psychologically, you can see a personality change. inappropriate behavior in somebody, paranoia, or even depression can present itself. There are various conditions and illnesses that cause dementia. The primary dementias are the Alzheimer's disease, Lewy body dementia, where the dementia is not related to any other condition or illness. There are the secondary dementias that are caused by another illness or condition, like Parkinson's disease or multiple sclerosis, or even an abuse to alcohol. And then there are dementias that can actually be treated, stopped, or even reversed. These are sometimes called pseudo-dementias. This is where the cause of the dementia can be treated, like a medication-induced dementia, or somebody that might be deficient in a vitamin or have a thyroid problem, or even depression can mimic the same signs of dementia. It is so important for healthcare professionals as our responsibility to understand what these dementias are and what they are not, and the best ways to help support these families.
Alzheimer's disease is a type of dementia being the broad category of conditions that develop with aging. You're not born with dementia, so it is something that is acquired, and you have to have cognitive impairment that significantly affects your ability to function in terms of your basic activities of daily living, or what's called your instrumental activities of daily living. Alzheimer's disease is the most common form of dementia in the United States. Alzheimer's disease is a neurodegenerative disorder that actually is a brain disease that actually causes the brain cells to die as it progresses. In terms of the hallmark features of Alzheimer's disease, you have to have memory impairment. Some folks will even say that memory impairment leads the way in an Alzheimer's type of dementia. So you have to have memory loss and then usually impairment in another area of function, whether it's in your ability to do your normal tasks of daily living, to be able to name words, for example, an anomia that is called. The other aspect of doing your activities can be called an apraxia, where you are told to do a task, but you're unable to physically perform it because you're not registering that task to be able to perform it. That type of thing. You can't have another medical condition coexisting that could be causing the memory impairment. That has to be excluded in order to have the diagnosis. You can't have an acute confusional state. Sometimes people become acutely ill. They develop something called a delirium. In the presence of delirium, you cannot diagnose someone with an Alzheimer's disease. So I would say that if you're trying to look at diagnosing someone with Alzheimer's disease, you have to have memory loss. You usually have to have impairment in your ability to do your basic activities of daily living. We have to exclude other diagnoses that could cause impairment in your thinking, and you can't have an acute illness such as an acute delirium. So when we look at other causes of dementia, the second leading cause in the United States would tend to be a vascular type of dementia. Vascular dementia is caused usually from events that occur from the cardiovascular or the cerebrovascular system that would cause strokes or cause problems with blood flow or possibly hemorrhage into the brain that is basically related to the vascular system. These patients many times may have some memory loss like we see in Alzheimer's disease, but they mainly have problems in executive functioning. And when tested on neuropsychologic testing, we see other areas of brain functioning slightly different than a traditional classic Alzheimer's disease. The other thing that's important in a vascular dementia is that the cognitive problems are linked to a cardiovascular or cerebrovascular event. So you actually see that type of correlation. So for example, you may have a patient where the family says, I think they had a TIA. Well, what they mean by that is a transient ischemic attack where the brain is not getting its normal blood flow, and then the patient may recover that, and then they go back to their baseline again. But they had that temporary appearance of not being able to think correctly, or maybe even function in terms of using their arm, their speech, etc. However, in vascular dementia, you have to have a burden of this vascular problem in the brain where it affects a significant amount of area in the gray matter of the brain that you can actually then see on an MRI scan or a CAT scan. The main thing with vascular dementia is that we believe we might be able to affect some of the risk factors. So if we address the cardiovascular risk factors, we may actually be able to have the patient stabilize and not show a continued progression of the dementing disorder. And so we sometimes talk about in vascular dementia a stair stepping, where you see the patient have an acute decline in their cognitive and possibly sometimes physical functioning. They then can stabilize until the next event occurs. That is very different than what we see in a progressive neurodegenerative disorder like Alzheimer's, where the decline is slow and continuous, as opposed to this type of stair-step condition. Lewy body dementia is one that probably, I would say, over the past 25 years, we've begun to categorize better as a cause of dementia. And these are patients who have signs of Parkinson's disease. We call that Parkinsonism, where they may have some rigidity in terms of their muscular functioning. They may have a bit of a tremor. They may have an unsteady gait that then would predispose them to falls. They also have hallucinations that are much more common in this disorder than in an Alzheimer's disease. Not that Alzheimer's disease can't cause some hallucinations in certain patients, but it is very much a hallmark of Lewy body dementia to have very vivid hallucinations. And these patients also have fluctuating attention that is more common in these types of patients. Many patients with Lewy body dementia can also have a sleep disturbance, which can be real challenging, particularly if you are a caregiver for this patient because of a sleep difficulty. And this is also a progressive neurologic disorder. The Parkinsonism has a temporal relationship to the cognitive impairment that we see in Lewy body dementia. What I mean by that is that you'd see within a few years the patient having cognitive impairment and then possibly the Parkinson-like symptoms and physical findings, or you may see some of that Parkinson's type findings, and then they develop the cognitive impairment in closer proximity within a few years, as opposed to someone who may have long-standing Parkinson's disease for possibly 15, 20 years, and then develops some cognitive impairment. That condition would be more likely Parkinson's disease dementia, as opposed to a Lewy body dementia. Frontotemporal dementia is mentioned to be about 5+% of all the types of dementia that we see. And this one, I would say, is probably one of the more challenging types of dementia to diagnose and to also manage. It tends to occur more in younger patients, meaning patients in their 50s or possibly 60s, and they can present with either a behavioral variant or a language variant type of disorder. For those with the behavioral variant, these patients can show some apathy, or they can be very obsessive and repetitive in certain behaviors. They can be quite disinhibited, where they start doing things that they had never done before. For example, possibly a patient that had never gambled and then just starts going on a gambling spree, to the point that families and those that know the patient, friends, may think they may have a psychiatric illness. And many of these patients actually wind up presenting to psychiatry because their behaviors are different than what they had been, and they don't appear to have sort of the normal stop sign or the control over behaviors that are different than what this person would have had in the past. Or possibly they may have language difficulties that they never had before, with in terms of naming things or being able to have fluent conversation like they've had in the past. We use the term mixed dementia when a patient on assessment, and in particular if we also do what's called neurocognitive assessment, has features on the testing that look like Alzheimer's disease patterning in their functioning, but then also appear to have vascular risk factors with some additional features of vascular dementia. So because of having features of both, we would tend to then say that these folks really meet criteria more for a mixed picture. When we're seeing patients that have concerns, or their family members have concern over memory impairment or a change in their function from the past, there's a standard approach that we would do to assessing the patient. Certainly, it's very important to get the caregiver or a family member, a friend, or someone who's a knowledgeable informant. I've actually had some patients where the knowledgeable informant was their accountant, or it could be their banker, because they've worked with them a lot. So you really want to find out from the knowledgeable informant, what are the changes that they're seeing, specific to changes in memory, changes in personality, changes in function from their baseline. So that would be really important. It's also important to assess the patient and ask them if they've noticed anything in terms of any changes in how they're functioning. We would also then do a physical examination like we do with any patient, with the focus being on the neurologic and cardiovascular systems, since most of the causes of the various types of dementia are related to the nervous system or cardiovascular effects. That would be very, very important to assess. We need to look at all the medications the patients are taking. There are many medications that can affect cognition, and therefore a thorough review of their medications would be extremely important. Of course, past medical history, which is very much a part of any complete physical exam. Additional components would be a cognitive assessment. There are many types of cognitive assessment tools that are available today. And in fact, as part of Medicare's annual wellness visit, they have a series of recommendations for various types of tools that could be used. Some of the common ones that have been used in the past are a mini mental status examination or a mini mental state exam, what's called a mini cog test, or a clock drawing test, and then there's one called a Montreal cognitive assessment tool or a general practice cognitive assessment tool. All these are readily available and can be utilized as a screening in order to determine, is there any abnormality in cognitive function that would include memory, attention, visual spatial relationships, etc. Another important tool is to do a depression screen, to really see if the person has signs or symptoms of depression. Patients with depression may have difficulty in cognition, so very important to screen for that. We also need to do an assessment of their basic activities of daily living and instrumental activities of daily living in order to see, are they able to function independently or not, which would be very, very helpful. Many times we'll also add, if there's concerns, screen for alcohol. If someone certainly is involved in, drinking alcohol, that could be an issue. And so we would want to screen for that. Obviously, any kind of illicit, drugs, things like that, that would be very, very important to assess the patient. Yeah, the ones that are very common to be used is CATS, assessment of basic activities of daily living, or a Brody Lawton instrumental activities of daily living. Many of these assessment tools now, fortunately, are actually being built into some electronic health records so that they are available to clinicians to use. Probably within the last year or so, the Alzheimer's Association actually has created a downloadable app for iPhones that is really extremely helpful, that has a section on it for the lay public, and then also a section for practitioners where you can actually access many of the diagnostic tools, the criteria, even treatment recommendations. So very, very helpful app. There's also on the website through CMS, through Medicare, talks about the annual wellness visit and actually talks about the various tools that can be used. And so they could also be downloaded. And so with the World Wide Web today and apps that we have for phones, all of this information and these various tools are readily accessible. In terms of doing an imaging study when you are assessing somebody for a possible dementing disorder, it's important to get a baseline related to anatomy. That can be done either with a CAT scan or an MRI scan. Many times the MRI scan is chosen if you are concerned that the person has vascular history and you are looking for areas of stroke that might be small. So that would be helpful. We now actually have PET scans that can be done that can look at functioning of glucose activity in the brain, and there's certain patterns that will relate to different types of dementia. And actually now we even have amyloid brain scanning that can be done, where you can actually see the amount of burden of amyloid. That in and of itself, however, is not 100% diagnostic. There are patients that have amyloid positive scans but do not have dementia, and there are patients, about 15%, that have amyloid negative scans that actually do have dementia. So it is not 100% diagnostic. You put it as part of your assessment in order to then make the diagnosis. So treatment for Alzheimer's disease today consists of a consideration of acetylcholinesterase inhibitors. These are medications that have been around now for probably close to 20 years or so, and they consist of donepezil or Aricept, or rivastigmine exelon, or galantamine razidine are the medications that can be utilized. They are once a day, or they're oral pill or a patch, and it really depends on the patient's overall clinical condition and other comorbid illnesses that they may have in terms of trying to determine which may be the best treatment plan for that patient. And this should be done in conjunction with a conversation with the caregiver, family member, as to what would be acceptable and to the patient. That's for mild, moderate, and severe stage. These medications are indicated. The other medication is called an NMDA receptor antagonist, or memantine, or Namenda was the trade name. This is indicated for moderate to severe dementia and can get added on. There is, in fact, a combination medication now that consists of the donepezil and memantine, where then the patient would just have to take one pill, but has actually the two components in it. So again, you want to look at the patient, comorbid illnesses, what family and patient find acceptable, and consider some of these medications that we do have now that treat the symptoms of Alzheimer's disease. They are not disease-modifying medications.
Well, I think when we went to see the neurologist, I expected a little bit more than I got from him. But at that point, I think we were so relieved that it wasn't a tumor or it wasn't cancer, that it was like, oh, we can deal with this. We can deal with Parkinson's. This is not a big issue at all. So there wasn't a lot of explanation. The doctor just said, oh, he's got Parkinson's. Go to the internet. You can read all about it. And I did, but, looking back, I think they should have been a little bit more helpful. And then as John didn't get any better, and I thought was getting worse, and then when I went in and said, he's not getting any better, I need something more. And, I said, I'd like to go to the Mayo Clinic. Will you help us get in? And he said, I don't know to go there. And I said, well, can you help us? Will you write us a letter? Go if you want to. So that's when I said, well, we'll go and period into it, and we'll get in. And he was like, good luck with that. And, that kind of sent me over the edge. So we did. We went to the Mayo Clinic, and we got the confirmation that he did have Parkinson's along with MSA, multiple system atrophy. And somewhere along the line, our neurologist here has said something about, he may have MSA. And, I think he does. Look it up on the computer. And that's when I looked it up on the computer, and that kills you. MSA will kill you. And so when we got to the Mayo Clinic, and I said, what, that was just flippantly said to me. And he apologized and said, I'm so sorry. Let me explain to you what this is. And he talked to John and said, let me help you understand this. And, I'm not giving you a death sentence, Mr. Smalling, but there is no cure for MSA, and there's no cure for Parkinson's. And so that was very helpful. And our neurologist said to us, we're getting a nurse practitioner, and she specializes in movement disorders. And, my dear was like, well, what do you specialize in? You're the neurologist. So, we said we're not going back. And then we went back to see his nurse practitioner, and she was fantastic. She just brought John right in and pulled her chair right up to him and talked directly to him. And, spent time with him. We never felt rushed. So she was very good.
When assessing a patient and then diagnosing them with Alzheimer's disease, I find that this is very different than many of the other diagnoses that we may make. And the reason why I believe this is very different is that because of the fact that this disease really impairs that person's ability to maintain their own independence and function, that it definitely will involve another individual who is usually their care partner, caregiver, that has to be involved. And so I really feel that you actually have two patients that you need to care about, even though that family member or care partner may not be your official patient, because if they don't take care of themselves and they are not maintaining their own health, then that will be detrimental to the person with this disease. The other piece of this is that because of the slow progression, this disease could occur for about 20 years. So it truly is a long journey for the doctor with the patient. and their caregiver. That's very, very important. There are also other aspects that occur because of the cognitive and functional impairment that have to be addressed that usually don't have to be addressed when you're diagnosing other illnesses, such as someone diagnosed with diabetes or high blood pressure. So, for example, when we first diagnose someone with Alzheimer's disease, we have to consider their ability to drive. Are they still capable of driving? Do they have firearms in the home? Are they capable of knowing when to use it or when not to use something? That could be a safety consideration. Can they continue to remain home alone or not? Is another important consideration. And another area that we believe is so important is engaging the patient in their own decision making to try and decide what would they want in the future when they're still capable of telling us in terms of advanced care planning. Who would they like to choose to speak for them when they no longer can? What about their legal matters, such as will, things like that. It's so important to try to get those aspects of their life in place when they're still capable. As I mentioned, when you're diagnosed with other medical conditions, such as high blood pressure or diabetes, you're still capable of making your own decisions. And so we may not have to address that during those diagnoses. But with Alzheimer's disease, we know that's what will occur, where the progression, it's a neurodegenerative disorder that will get worse. And how do we begin to plan so that you can take charge a bit of what's going to happen in the future and actually plan for that? So that does take more time. And so that's why really having, Medicare look at now care planning codes for billing is very important, because these kinds of discussions take more time. Medicare actually recognizing now, that physicians can bill for advanced care planning discussions. Very, very important, because it does take time to have these kinds of crucial conversations, and sometimes quite challenging conversations.
So, talking about how to share bad information or the condition of a loved one, you have to take many things in consideration. One of the things I always ask are, what does the family already know about their loved one's condition? Then I ask which family members are present and what have they been told. So it's a process of understanding their expectations, they understand the disease process, and then gently going from there. There have been many occasions where I've had to assess, again, how much they know, how ready they are for the information, and I never like to surprise them with saying your loved one is terminal, they only have so much time left. So it's talking to them ahead of time and feeling out what they know and what they're ready to know.
It's important to remember and focus on the individual and know that each one of us is unique and they all have an individualized approach. What works with me may not work with you or your family. So keep that in mind as you're discussing these conversations. Some families want everyone involved. Some just want one or two. The family could be clergy, it could be neighbors, it could be a best friend, in addition to the family. So have those people involved and engaged as that person wants it. Another aspect is where the conversation. If mom always had difficult conversations with a cup of coffee sitting at the kitchen table, then have a cup of coffee, sit at a table, have that discussion. Focus on what's important to that person.
The manner in which bad news or difficult information is communicated can have a profound effect on patients and their care partners. An understanding of a diagnosis, potential treatments and outcomes, along with the well-being and quality of life for patients, hangs on how effectively the healthcare professional delivers the information. The 6-step SPIKES protocol is widely used by health professionals for breaking bad news and sharing unfavorable information. This practical step-by-step framework includes setting up the interview, assessing the patient's perception, obtaining the patient's invitation, giving knowledge and information to the patient, addressing the patient's emotions and empathetic response, and strategy and summary.
It's very important to keep cultural backgrounds in consideration in these discussions. It not only builds respect and trust with the individual and their families, but it builds that connection in that relationship. Cultures vary in how we communicate. It's interesting, some cultures hear with their eyes, some cultures hear with their ears, and it's important to know that. So that you can look at what nonverbal communication they're looking for, how things are said, the tone of voice. Space is another thing, can vary by culture. Some want a distance in their communication with others, some need that closer connection. Another aspect of culture is, what are their views? What are their views on medical care? What are their views on dying? What are their views on end-of-life issues? One culture sees end-of-life decisions are made by the oldest son. Another culture thinks if you're being too direct in your conversation that you're being rude and offensive. So they want more general statements. So really focusing on what their culture is helps build that conversation, helps build that trust in their journey through this disease.
So Alzheimer's disease has a progression, and it's very important to try to measure that progression with the tools that we use for diagnosis. So for example, in seeing a patient with a progressive dementia, you would periodically, and in our practice, we tend to annually try to repeat the cognitive assessment to see if they have changed from a mild stage to moderate severe, or at a certain point in time, if the person lives long enough, they will be at advanced stage. The functional assessment tools, trying to see can they still perform their instrumental activities of daily living or not. Once a person is unable to continue to perform instrumental activities, which include things like doing your own shopping, doing your own cleaning, being able to use your telephone, manage your own transportation. Once you're not able to do those activities, then you have to have another person assisting you in maintaining independence in your home. So it's a very important measure to know when additional assistance would be needed. And the same way with your basic activities of daily living. So that would be very helpful. A depression screen we would do early on, mild and moderate. However, when the person then would progress, you're not going to be able to do the typical geriatric depression scale, or one where you're inquiring with the patient. You then have to have an observational scale, something such as a Cornell depression scale, where the person's caring for the individual observes them, fills out the scale, and that will give you some sense as to whether depression might be a factor or not. So yes, it's very important to look at the progression and then determine what is needed at that point in time in terms of levels of support for the individual with the condition. Dr. Reisberg created a FAST scale, functional assessment scale, that has 7 stages to it, that again helps us in terms of looking at where is the person on the trajectory of the disease, and then what level of support will they need, and also what level of support may that caregiver need who's trying to help manage their family member along the journey.
When someone's not in the office, when they're caring for their loved one at home, I think it's very important to lay out a treatment plan. what they can expect as their loved one progresses through any disease process, what their expectations are, what their loved one is able to do and not do, and what they can expect to happen as their condition progresses. That way they know if their loved one all of a sudden has no appetite, does not want to eat, that's a natural part of the disease progression.
It's keeping them informed. It's giving them information about the disease. It's helping them look forward, not only to look at what they're dealing with now, what's going on right now, but to look at what's up the road, and helping them realize they have options. What we normally see for a healthy person as far as aggressive treatments are not always what we're looking for with someone with dementia. And families don't realize they have choices. And providing that education and that support is helpful. Providing reassurance, too, is key, so that they know they're not alone in making these decisions. Helping them walk through that, because sometimes they'll say, well, we've never had this conversation. But ask around. Sometimes they have a best friend who comes to visit them, and they've had that conversation. And giving that family member that information is helpful, dealing with those difficult choices. What I love about my work is being able to connect with each person, family members, but mostly the individuals who are lost in this disease. They're still in there, and there's connections are possible, and it's just wonderful to celebrate the joyful celebrations with them, and to be them when they're struggling. And that connection is there, and sometimes most often that connection is there long after they've lost the ability to talk. So, in their dying breaths, you're holding their hand, and you tell them you love them, they squeeze your hand. That's what I love about my job.
Some really good sources of professional education include the National Institutes of Health, really good materials for both professionals and lay people. The Alzheimer's Foundation of America also has a lot of good professional education materials, and the American Geriatric Society is also a good source.
So when diagnosing and managing patients that have Alzheimer's disease, it's really important to know about the community resources available. And a great resource is your local chapter of the Alzheimer's Association. There are early stage support groups, later stage support groups for the patients. There's actually support groups for the care partner, caregivers. There's education programs that they offer. And then they also can inform you about various research that's available. There's actually a website for the trials.gov that can then enable you to look to see, is there something I can participate in the local area in terms of research in the area. Of course, as a person might need more supports in their home, and if they're trying to continue to manage at home by themselves with just occasional caregiver support, other things such as Meals on Wheels, there's senior citizen services where congregate meals can be served is very, very important. Also, something that I feel is really important, and there's actually some literature starting to support this today, and we hope to have more in the future, is the whole need for exercise and physical activity being really important for the person with the disease and very much for the caregiver trying to continue to take care of the patient. So looking at resources in the community in terms of exercise programs, YMCAs, YWCAs, very helpful, and then various hospitals have programs. And then also looking at fall prevention, because patients with progressive dementias do tend to have a higher incidence of falling because of the cognitive impairments. And so looking at how to prevent falls, how to look at your home to make sure it's as safe as possible possible to try and prevent something like that.
In terms of patient education, I consider the Alzheimer's Association the go-to agency. They have a wealth of resource information as well as caregiver support groups and other direct services that can be really helpful. Another good source of resource information is 211. It's part of a statewide network. It can be accessed 24 hours a day, 7 days a week. And then the area agencies on aging are great sources of both resource information as well as direct services such as respite care, benefits counseling, information about long-term care facilities if families are thinking about placement at some point.
Thank you for joining us today. By now, you should have a deeper understanding of the unique challenges you'll face as a healthcare provider for someone with dementia. Today's program is a general overview, but putting what you've learned into practice is up to you. We've provided links to the resources we find most helpful in clinical practice. We recommend that you use those resources as a starting point to develop your team's approach to better, more compassionate care for your aging patients. Today's video is the first in a series that we've developed to help you understand the complexities of caring for your patients with dementia. The additional videos will take a deeper dive into some of the more challenging aspects of care, so we hope you join us for those. Thank you.